Today we have our esteemed faculty, and we'll be discussing about remote monitoring devices in ICU and in the ward and out of the hospital also. So we all know that the remote monitoring devices are used at home and in the hospital also. Many a times when we shift the patients from the ICU to the ward, who is fitting to the criteria of shift out criteria and all, many times we'll get calls from the ward after the patient worsening, code blues, all those things calls we'll get. So to reduce that rate, we are already using the remote monitoring system in the ward, wherein the like vitals will be monitored from the ward in a central monitoring system. And whenever the patient's METS criteria if a news criteria is filled, then the Metcall or the rapid response team will go and evaluate the patient, and early initiation of the management and reduction in the, it also gives the patient safety and reduce the code blue rates in the hospital. And it is also having a very good role in the perioperative and postoperative patients safety also. And so regarding that, in a remote monitoring systems, like in the resource limited settings, in the peripheral hospitals and all, managing the ICU with the help of tele-ICU technology with the tertiary hospital. So regarding this, we have various varieties of remote monitoring system. It can be a watch which we are wearing, smartwatch, which can capture the vitals and the variations of the heart rate with the exercises and sleep pattern. So like this, we have various devices of remote monitoring system at home and in the hospital, and for diagnostic purpose, and for many a times in the therapeutic areas also, like in physiotherapy, monitoring the patients from the hospital at home. And regarding this, let us know more in detail from our esteemed faculty. Let us welcome our first speaker, Dr. Ashish K. Khanna. Sir is presently working as a professor and vice chair of research, director of perioperative outcomes and informatics, collaborative, Department of Anesthesiology, section of critical care medicine at Wake Forest School of Medicine, North Carolina, United States. Welcome you, sir.
Hello.
And our second speaker is Dr. ARJUN ALVA. He is currently working as a Director of Critical Care and Emergency Medical Services in Narayana, Bangalore. Welcome, ARJUN.
Good evening, everybody.
So let us start with our first presentation on remote monitoring system by Dr. Ashish Khanna. Over to you, sir.
Thank you. Thank you, Ramesh, and good evening to friends in India. I'll start by saying that, remote monitoring is a rapidly advancing field, and as Ramesh said in his introduction, the opportunities are endless, and where we can apply it, those avenues are also rapidly increasing. I have about half an hour for my talk today, so keeping time as a constraint, I will limit myself to more of the inpatient environment, but I will agree with Ramesh that, we have already started using remote monitoring devices outside the hospital and on patients going home, and in the preoperative environment as well, with great outcomes. So maybe we can talk about that at a future opportunity. These are some of my relevant disclosures. None of this is a conflict with the academic content on my slides today. I'm going to start with some very sobering data for those of us, especially who practice in anesthesia, surgery, or in critical care. Post-operative deaths if taken as a disease entity in and of itself, are the third most common global cause of mortality, only after ischemic heart diseases and stroke. And this is data not just from the developing world, but also from middle and high-income countries, which really means that our patients are doing well during their surgical operations, but they are not able to go home. They are having serious complications in the immediate postoperative period in the first 30 days after surgery. This is really relevant information for us, and I want you to focus on this when I transition to my next slide. Here you see this yellow circle, the small yellow circle within this large gray circle. This small yellow circle is intraoperative mortality. Intraoperative mortality is only 1% of this big gray circle, which is total 30-day mortality. Again, going back to my last slide, postoperative deaths are really, really common. The intraoperative period is really safe. Intraoperative mortality is so low that it's difficult to quantitate it, which again means that while we operate on older, sicker, frailer, and more complex patients all the time, the safety of anesthesia and surgery has increased to a point that a large majority, almost all of these patients get through surgery without a problem. But then during their index hospitalization, these patients have serious complications leading to morbidity and or mortality. This is a wake-up call for us as perioperative physicians, as anesthesiologists, surgeons, and intensivists who work in this area. And I work most of my time in critical care, but I say this, that we need to look beyond the ICU. We leave our patients under-monitored outside the ICU. The top 3 bullet points on this slide suggest data that clearly tells this story. 3/4 of patients who died in the hospital were never admitted to an ICU at any stage after surgery. This is the famous USOS study. About half of all adverse events in hospitalized patients occur on the general care floor, and when they do happen, they account for about 85% of all postoperative mortality. Importantly, keeping all of this in perspective, that adverse events are common on the general care floor, and a lot of these patients just die. The really critical part is that about 80% of these patients who are going to have adverse events can be identified up to 24 hours before the actual index event that leads to downstream mortality. So this is a preventable and a an early actionable cause where we can intervene early and prevent downstream critical events. Code blues don't really occur out of the blue. The data here suggests that as the number of pre-arrest abnormal vital signs increases, that you see on the x-axis here, so does the mortality after a code blue event. Importantly, about 2/3 of all patients have at least one abnormal vital sign 1 to 4 hours before a cardiorespiratory arrest, right? So again, if we are able to capture these abnormal pre-arrest vital signs, and if we're able to intervene early, we can probably keep the mortality after the event down as well. But mostly we capture these abnormal pre-arrest vital signs. We don't capture them at all, or we capture them very late. So post-arrest mortality is very, very, very high. Now, this infographic here is a real simple depiction of the current state of affairs and the problem. Currently, on hospital wards all over the world, we do spot checks monitoring, which means a nurse or a resident or a provider goes into a room and checks vital signs. At least in the US, it's once every 4 hours. Some places once every 6 hours. Some other places it's once every shift. On the left side here, you see that situation. This is 4 o'clock at night. A patient's resting comfortably in bed. About 4:40 in the morning, this patient is progressively turning blue because of either an obstructive event or another event. And when the provider actually goes to the room 6 o'clock in the morning and does a set of vital signs, these are pre-arrest vital signs. The patient's ready to code. As I just showed you, as the number of pre-arrest vital signs, abnormal pre-arrest vital signs increases, so does the poor outcome after a code blue event. This has already transpired on the left side, as you see it, into a a sort of a non-salvageable situation in a code blue event. On the right side, though, is where we want to be. We want to be in a situation where our patients could have some sort of smart continuous monitoring system, which is portable. With these patients would be continuously transmitting their vital signs via Bluetooth or Wi-Fi or another secure band like that, and there would be a immediate response and alert system. Both the afferent and the efferent arm would be really strong, and there would be early interventions to save the patient from an unplanned ICU admission or a rapid response call or a code blue event. Now, all of this looks really, really simple. You would say, hey, if it's that simple and that easy, why don't we just put continuous monitoring for everyone on the floor? Well, there is a lot more to it, and I'll be getting to that in just a second. But I also want to give you guys some other perspective. Now, for all of us who practice anesthesia in the operating room, we know that we normally check blood pressure once every 5 minutes for a usual surgery under general or regional anesthesia, which means that if it's a median surgical duration of about 130 minutes, we're checking blood pressure 26 times in about a 2 hours duration. The same patient then transitions to the recovery room and then goes to the hospital floor. Vital signs are then checked once every 4 hours, which means if a patient stays in the hospital for 3 days, you're checking blood pressure now 18 times over 3 days. So you've gone from 26 times in 2 hours to 18 times in the next 3 days. And then the same patient goes home, never to be checked again, and only told to come back to the ER in case they feel unwell or they feel that something's wrong. Again, we are totally throwing our patients off the monitoring cliff. We are taking the same sick and frail patient. We're doing intensive monitoring in the operating room, but then we're suddenly stopping all sorts of monitoring and leaving our patients to their own accord afterwards. In the British Journal of Anesthesia, we've just published this really nice review with colleagues in Germany, Moritz Flick and Bernd Sagel, who are both doing great work in this field. And this infographic here again tells the same story that I've been telling you in the last 5 minutes or so. If this is a patient at 8 a.m. in the morning, and the top part is intermittent manual monitoring of vital signs, you see how much of a delay there is at each step. The step at which vital signs are checked, the step at which the rapid response is called, and so on. In the bottom part of this panel, you see the ideal environment with continuous automated monitoring, where there would be early transmission of altered vital signs. There would be some sort of AI-based engine to clear the noise and artifact. There'd be an early intervention system and an early prompt clinical intervention. So highly recommend this. This piece has a lot of valuable information for the audiences on this webinar. Bernd Sagel in Hamburg has also come up with what he calls the smart um, way of ward monitoring. So SMART stands for appropriate patient selection. That's the S. M is appropriate monitoring systems, and I'll come to that in my slides to follow. A is appropriate alarm thresholds. R is responding early, and T is treatment that you can do on the floor. As you know that you cannot do a lot of things on the floor. You cannot start vasopressors. You cannot go above and beyond a certain amount of respiratory support. You cannot give code drugs on the floor. So you have to know what treatments you can do on the floor to prevent your patients from going to the intensive care unit and how you're going to act early enough. So monitoring is okay, but being smart about monitoring is also really important. And then my favorite analogy is comparing the use of monitoring to modern day aviation. Aviation cockpits look just about like this on any major airline or aircraft that all of us use all the time to travel. One of the reasons why aviation is so safe is that every single movement of the airplane is continuously being captured and transmitted to ground control and also being stored in an internal flight data recorder. This means that aviation is learning every flight, every episode of turbulence or every unfortunate poor outcome, aviation learns and then plans for the future for a safer future. We are not doing that with our patients on the floor. We are letting them sit without monitoring, which means that if they code, if they have an unplanned ICU admission, we don't really understand where it came from, and we cannot plan a future where we can make care safer and know these digital signals that our patients will transmit early enough so we can act in an early and proactive manner. Now, after all of that, I think I've probably convinced you that we do need continuous monitoring or outside the ICU. We do need to monitor our patients better on the floor. I want to share with you some data in the next 15 or 20 minutes. Now, this is a work that we did at the Cleveland Clinic. We put continuous blood pressure monitoring on surgical patients on the hospital ward. The blood pressure monitoring was every 15 seconds. The monitor itself was silenced and blinded to the nurses and providers, which means that the nurses and providers were doing their usual spot check monitoring. What we saw was interesting and some might say rather disturbing. So on the y-axis here is the percentage of patients. A fifth of patients with this green arrowhead had on the x-axis here a map of 65 or less for at least about 30 continuous minutes of monitoring time. Importantly, spot checks or traditional checks missed about half of all episodes of maps less than 65 that were detected with continuous monitoring. So hypotension was being missed. Now, we've also done experiments with respiratory depression. This is the Prodigy study that we published about 5 years ago, the prediction of opioid-induced respiratory depression on inpatient wards using continuous capnography and oximetry. Here, patients after surgery were put on continuous capnography and oximetry. Again, monitoring was blinded and silenced. These patients were patients who were receiving opioids as analgesia. The monitoring device was itself not portable. It was a box that had the patients tethered to the bed. The data was again very interesting, and the headline was that about half of our patients had at least one opioid-induced respiratory depression episode that was detected with continuous monitoring, and which was probably not detected with intermittent traditional vital signs checks. Again, showing thereby that there is a lot to be uncovered if we are going to continuously monitor our patients. The other question people ask me is that if I do wireless wearable monitoring or continuous monitoring, what vital sign should I focus on? The one vital sign that has stood out here is continuous respiratory rate. On the x-axis here is the AUC ROC of a downstream clinically relevant adverse event. On the x-axis are various vital signs. Respiratory rate is the one that is the most strongest predictor of a downstream clinical event. The unfortunate problem is that respiratory rate, at least in the US and most other parts of the world, is the one vital sign that is often wrongly and inaccurately stated and documented and checked. Um, this picture here tells a story. These big yellow dots are intermittently checked respiratory rate that have been manually checked and documented in the EMR. As you can say, that number is around somewhere around 18 all the time. The blue dots clustered together is a wireless wearable device that is continuously monitoring respiratory rate. You see here how there is tachypnea that is pretty obvious as a trend here that intermittent monitoring has not been able to pick up. The purple line here is an actual ICU transfer event, and as is obvious here, this could have been prevented if intervention had been done early enough and this trajectory had been seen. Ironically, right at the time of ICU transfer, again, the respiratory rate is still documented as a manually documented erroneous respiratory rate of 16 to 18. And that is a situation that we really need to prevent with continuous monitoring. Now, there's lots and lots of devices and patches out there, and won't go into details today, but one of the problems is that We don't know how to choose what is the appropriate patch or device for our hospital system. One of the biggest problems is that we need to accurately validate measurement systems. And with Bernd Sagel, we wrote an editorial in anesthesiology where we provided three-step process here. Validation of measurement performance. It's very important when any device vendor comes to you and says that they have a continuous monitoring device. Number two is challenging the device to go through an interventional outcome study, hopefully a randomized trial, where you can look at clinically relevant outcomes. And number three is implementing in clinical practice, which I will tell you is the most challenging part of doing all of this, because like I just said, it's not just about putting continuous monitoring on everyone on the floor. You've got to understand the downstream ramifications of alarm fatigue and non-actionable alarms and technical alerts and so on and so forth. So we asked anesthesiologists in Western Europe and the US, we said, okay, what do you want from continuous wireless wearable monitoring? Um, one of the data points here, one of the questions was, what are the main implementation challenges to continuous ward monitoring? And the three things that stood out were, number one, economic, that is the return on investment. It is not a billable service in the United States. So if we put continuous monitoring on someone, we are not generating revenue for the hospital. Rather, the hospital is spending a lot of money in setting up these systems. Number two is connectivity robustness, which means that you can put continuous monitoring on your patients, but this generates terabytes of data every day. And do you have the right servers, the bandwidth in your IT systems to support this data so there's no data loss as you're doing this? And number three is alarm management strategies, which lead to a lot of nursing and pushback from the floor, which is honestly a very, very challenging part with continuous ward monitoring. So there is possibly a role for AI in all of this, and I'll get to that in the future as well. But keep that in mind as you think about implementing continuous monitoring on the floor. This is what we've used at my local system here at Wake Forest and all of our hospitals, especially our mothership here. We have a device that continuously measures EKG, heart rate, SpO2, blood pressure, respiratory rate, skin temperature, and also position, body position, mobility, and atrial fibrillation. This is what it looks like. We've been using it for the last 6 years, 7 years or so. It's completely wireless technology at some stage. As a patient, a local data server and remote cloud storage, that's how the device data will flow. This is, if you come to the hospital and you walk through the hospital wards, this is what you'll see. On the top is these individual patient rooms, and you'll see every 15 seconds these vital signs will change. If you tap on any of these, it can open up and you can see all of the vital signs come through. We've done some interesting work with this data. And this one thing is we looked at postoperative hypotension, similar to the earlier experiment at Cleveland Clinic that I showed you, but different because our monitoring is not blinded and silenced. This is real world data. So our monitors are open, our alarms are open. We use this continuous monitoring. We did not see as much postoperative hypotension. Only about 10% of our patients here on the y-axis had 30 continuous minutes of MAPS less than 70. Okay, much larger data set. This is about 15,000 patients. I can safely say that alarms and interventions may help to decrease the burden of postoperative vital signs changes. Now, it's interesting that, one part of me, obviously, I'm going to say this, that we are decreasing the burden of postoperative vital signs changes if we do continuous monitoring. But we still don't really know whether it makes a difference in hard patient-centric outcomes. And patient-centric outcomes being myocardial infarctions, myocardial injury, or acute kidney injury, and major cerebrovascular events, things that would be dependent on blood pressure swings and hypotension. We also have lots of data on here oxygen saturation. X-axis is oxygen saturation, y-axis is percentage of patients, and different colored lines denoting the total time spent, continuous minutes under various SpO2 thresholds. Again, we keep our SpO2 alarm at 85 for patients on the floor. So beyond 85, this drops off pretty sharply here. With respiratory rate, same situation. our alarms are kept anywhere between 6 and 8 of a lower respiratory rate threshold. So it drops off pretty sharply after 6 here. So what about the other evidence? I talked about patient level, patient centric outcomes. A lot of the studies that have been done, in fact, all of the studies that have been done are prospective before and after studies or retrospective studies. And some of them have used wireless systems. A lot of them have looked at rescue events, ICU transfers, and cardiac arrest. But these are prospective before and after studies. This one with the red arrowhead actually came from our institution. Again, we saw a decrease in rapid response team events after the implementation of continuous monitoring. Now, um, the before and after study design, and again used here in this recent study published in the BJAA, has some inherent problems. One of the biggest problems is that there is this it's difficult to clearly separate the effect of the intervention versus the effect of time, which means that um, ICU admissions and rapid response calls might have just declined over time, and you would falsely attribute it to the effect of the intervention. Now, the investigators here are showing that there's a pretty significant decrease in ICU admissions and rapid response calls in this before and after study that came from the Netherlands. But again, it's very difficult to say whether this was because of the intervention that was wireless vital sign monitoring, or was it just an effect over time. We have done another analysis using a interesting approach where, as we implemented continuous monitoring in our hospital system, there was a lot of patients who did not have continuous monitoring, so they served as natural controls. We retrospectively looked at our data and we propensity matched those patients who did not have continuous monitoring to those patients who did. And in our analysis, where a composite outcome looked at in hospital mortality and ICU admission, we did see a composite that favored continuous monitoring. We also saw that outcomes such as heart failure, MI, acute kidney injury were all in favor of continuous monitoring. So, again, not randomized trial data, but still a pretty strong signal in favor of continuous ward monitoring. We've recently also completed this. It's a prospective cluster randomized trial of continuous portable hemodynamic and oxygen monitoring on postoperative patients on hospital wards. This was an interesting study design we used. We took 2 hospital wards and every 4 week switched them from continuous monitoring to intermittent monitoring, the U being continuous monitoring and the B being intermittent monitoring, where we blinded the continuous monitoring system. We made these switches over a period of a year, so we kept this pragmatic, cluster randomized, and we were able to enroll lots and lots of patients. Our primary outcomes were the risk and duration of hypotension, tachycardia, and hypoxemia. And there was a statistically significant difference as far as hypotension and hypoxemia is concerned, both in favor of continuous monitoring. Not so for tachycardia. And not so for a lot of other blood pressure component thresholds we looked at and heart rate thresholds. However, our composite outcomes, so the composite of hypotension, tachycardia, and hypoxemia, and composite B that included hypertension and bradycardia, were all in favor of continuous monitoring. Finally, we checked troponins on all of these patients in the 2 arms. So in a cluster randomized design, we're checking whether there is indeed an impact of continuous monitoring. If continuous monitoring does decrease blood pressure changes or does decrease hypotension, it should decrease myocardial injury as well, which is directly related to the amount of hypotension postoperatively. Interestingly, here we have not seen a difference in myocardial injury. This is still unpublished data, hopefully soon to be published. But again, the message here being, and I can talk more about this in the future, we did not see persistent, prolonged durations of hypotension as a difference in the 2 arms. We did see a pretty significant difference in desaturation, but not with hypotension. So what's the future? Well, we still need to search for improved perioperative patient safety solutions. We need to look at cost, return on investment, alarm fatigue, finding the right intervention systems. And this is a infographic that appears in our BJA paper. There's a lot to look at. We have to look at the sensor, we have to look at data processing, we have to look at alarms, and then we have to look at appropriate treatment. And there is enough here that it will take us a few years to get to the right sensor, right data processing, right alarms, and right and appropriate treatment to make continuous monitoring a solution that is viable on the general care floor. I also want to briefly touch on the role of continuous EKG. I think that with you know opportunities and innovations like this is called the analytic of hemodynamic instability that uses raw EKG data and converts it into a signal. And the green signal means that your patient is doing okay. Yellow means you're on standby, and red means that your patient's not doing okay. And there is the onset of hemodynamic instability that has ultimately led to a rapid response call. Now we have seen that using this system, there is a very significant gain in time for the prediction of a downstream rapid response event compared to just using raw vital signs by themselves. So again, the idea there being that if you provide this kind of system on the floor, it'll be easier to digest and respond and to filter out noise that comes from continuous raw vital signs versus looking at a consolidated signal such as continuous EKG. We've also worked a lot on the mobility part of things. We now have mobility and posture data on from patients on the floor. And this was an important paper that we published in JAMA Surgery a couple of years ago, where we saw in a retrospective confounder controlled analysis that every 4 minutes of mobilization per hour had about a 30% associated decrease in the odds of a set of primary outcomes that included myocardial injury, stroke, thromboembolism, pulmonary complications, and mortality. And even though this is retrospective, which means that despite our best efforts at controlling confounders, there is still the threat of confounders that are not obvious. It does need to be changed, and that does need to inspire us to do prospective trials where mobility is one of the interventions along with continuous monitoring. So what's the future? The future is we should have lots and lots of raw data. We should have waveform data too that should allow us to detect patterns for patients on the floor. Here is data from the Prodigy study. This purple line here is again a rapid response event. The blue is the end-tidal CO2, and there's lots and lots of periods of apnea that precede this rapid response event. Again, down here, this is the heart rate, and you see the heart rate has started looking. There's been a lot of up and down variability in heart rate right before this rapid response event. So again, an opportunity for us to intervene early, looking at pattern detection. Looking at a cluster of vital signs, we should be able to use machine learning to actually provide diagnoses. So for providers on the floor, they should be able they should be smarter systems that instead of letting them figure out vital signs, actually give them the diagnosis that helps. So the future is probably either of these slides, and it's here that hospitals would have continuous monitoring. There would be an AI engine that filters the noise. There would be electronic records and lab results that come into this AI engine. There would be a monitoring center that looks at all of this and then is able to notify the ward and allow for early interventions. We don't need more reasons for continuous monitoring, but just to again summarize, patients are older. There's a huge nursing shortage, especially in this part of the world. There's risk of lots of complications after high-risk surgery. Opioid-induced respiratory depression is again a huge issue in this part of the world. ICU bed shortage is also a huge issue in this part of the world. So we really need to mitigate all of that and get continuous monitoring so our patients can stay on the floor. What next is we still need to do appropriate trials. We don't have a lot of randomized, large, appropriately powered trials. We need AI and ML-based algorithms to detect patient deterioration early. We need analysis of alarm fatigue with modeling of alarm thresholds. We need to construct a set of postoperative patient safety guidelines, have a patient monitoring consortium, and really take ownership of the space of perioperative patient safety. This man is Daniel Sessler. He's one of my mentors in the field of perioperative outcomes research. And at our recent American Society of Anesthesiologists meeting, Dan gave a named lecture called the Rovenstein Lecture. It was titled The Gathering Storm. And as the headline here suggests, he said, is anesthesia's fourth branch headed our way, which he meant in this context was intensive post-operative monitoring, because he truly believed that we have to step out and monitor our patients better on the floor. With that, I thank you all. This is my research team that does all of this great work at Wake Forest. And I thank you all for this opportunity. I'm looking forward to questions.
Yes, sir. Thank you, sir. It was a great presentation. Many times we'll see patients coming with remote monitoring system or smart watches to the cardiologist, telling that the heart rate has reduced and the alarm systems and all. So many patients, even recently also we got a patient while doing exercise, he had heart rate is going down instead of increasing. So with this, I'll come back to you, sir, with some questions. Dr. Arjun had some experience with modifying the HAS system in the ICU. How we can consolidate the data and then ease the doctors in integrating that one and how it has helped in the COVID pandemic. So over to you, Arjun, for your presentation.
Going to share my screen. Can you see my screen?
Yeah, I can.
Okay. First of all, congratulations, Dr. Ashish. There's plenty of work that you and your team have done. Really appreciate and to what you're doing to the critical care society. Thank you, Ramesh, for this opportunity to just be here in this forum and listen to Dr. Ashish talk about remote monitoring as well. I just want to speak for the next 8 to 10 minutes. It's a very short lecture of how I, as an intensivist, have used the remote monitoring system and how we are using it currently in our intensive care unit. So this is the hospital where we work. It's called Narayana Health Bangalore. It's a 1,000-bedded hospital. We have about 400 intensive care unit beds, adult and pediatric. Along with that, we have about 60-bedded emergency room as well. So it's a big intensive care unit, big emergency unit. So our work with remote monitoring started during the COVID time. So this was the initial times where we started using this, and then this was in the wards. So this was something called as a Padma Vitals by one of the engineers who was working with us. He devised this a wireless device which transmits the data via the Bluetooth to a receiver that was placed near the patient bed, and then via the Wi-Fi to a central nursing station where the data is displayed continuously. And from there, through the cloud, it would enter into, it would transmit to, again, centralized places, and also into the phones of mobile phones of the doctors. This was again during the COVID time, so that we did not have to visit all the patients all the time. Again, validation was not there during that time at all. Just trying to change it. So we tried to validate it with the monitor that we had at that time to see, and this was the first time we were using it. So we wanted to see how whether the heart rate in our Mindray monitor was matching with the distant monitor that we had. So this monitor would give us the heart rate, the respiratory rate, the oxygen saturation, and the body temperature. And we did a study on about 60 patients, and it did match with the standard monitor that we were using. And it did help. We almost used this monitor as a trial basis for almost 3 to 4 months, and it did help in doing our rounds in a better way, to monitoring these patients in a better way in the wards during the pandemic time. So this is how the monitor, this Padma Vitals worked, where We had put multiple monitors on the patients in the ward, and as described, central nursing station, the cloud, and then 2 different central stations. And it also was being projected to our computers, our personalized computers and telephones, through which we were distantly monitoring the patient, and so that we can shift them to the intensive care units if necessary. Now we've moved over the past post-COVID. We've again, Narayana Health has worked on a few applications. So these are the few applications that we use in the hospital. Atma, which is a computer-based hospital management application. Adi is a advanced Atma application for Doctors Insight. This is on a phone. Nama is for the nurses that we use, and NH Care is our basic thing. So this is how our Adi appears on the mobile phone with our unique ID number and with the password. So it helps in real-time access to critical care patients. It increased the efficiency and accuracy of work, and also helped in video consultations, appointing schedules, etc. So how does it work? So this is basically an electronic medical record system. So what we currently do is us as a 70-bedded medical intensive care unit. So we try to cover it 24/7. So till 10 o'clock in the night, we have ICU consultants who are there on the floor. But the main problem happens between 10 in the night to 8 in the morning. That is when we don't have the senior consultants who are on the floor all the time. Instead, we have residents who've passed out of their anesthesia program, and the number of residents to cover the entire 70 ICU beds becomes slightly difficult. So what we have done is we started working on this system, Adi, where the ICU consultants are doing rounds using this application through the night as well. So they do rounds at 2 o'clock in the night, 6 o'clock in the 2 o'clock in the morning, 6 o'clock in the morning, with the Microsoft Teams, where they're using their telephone to do a WhatsApp call or Microsoft Teams, and at the same time sit at home and open each patient's details and go through it with the doctors there. So it has. So if you see, this is how, when you open it, this is how it will be there. You can view their past records. If it's a new admission, you can view their past records, what is going on with them. And if you open one of the, you have their investigation orders, medication orders, everything that is necessary for the patient documentation. Everything is available in these modules. Just giving you examples. This is how the progress reports are there. So you get more detailed information just sitting at your home. So you know what has happened through the day, progress notes every 4th hour. So you know what was the plan for the day. You also can have these, the lab investigations, everything are visible on the phone itself. We also have the echocardiograms, chest X-ray. These are all dynamic. As ECG is monitored, they scan the QR code, and automatically it comes into the Adi device. Adi and Atma. Adi is the telephonic one. So you can sit at home and visualize it without even giving a call to anybody. So this is a dynamic process which continuously goes on. It's an electronic media system which is very much helpful to the intensive care doctors at home. The one important other option, what we really like, is the family communication. New admissions, we have about 10 to 12 admission on an average night in our intensive care unit, in our medical intensive care unit. So the sick patients, they expect the consultants to be speaking to them. So directly using the application without sharing your personal mobile numbers, we are able to communicate with the family, because the phone numbers are there. You give a phone, it goes to the hospital number, and from there it goes to the family. You can also send a message to the family giving the updates of the family members, and they receive the details. So this has really helped us in having a very good communication with the patient family members. Also, we are, there is also this option where we can dynamically see the patient monitor. So you open the patient details, the patient's the whole monitor is visible for you sitting at home. And we are also working on integrating the ventilators with this application as well, so that we can look at how the ventilators are. We can also see what infusions are going on, and everything can be integrated into this mobile. It's very, very helpful during our regular work. We've also, this is a NAMA, which is a nursing application where they fill in their requirements, their assessment on a day-to-day basis. They do their blood pressures, heart rate, vital monitoring, charting on every 5 minutes, and that gets automatically picked up by the application, and it goes into the master chart. Along with that, whatever is necessary, whatever they are supposed to be doing on the paper is currently on electronic medical record system. That not only for doctors but also for nurses. We are almost 60 to 80% paper free in the hospital currently. So last couple of slides. So this is how our master chart looks like, which again, ICU consultants sitting back at home can just dynamically understand what is going on with the patient. That includes the infusion, what infusions are going on, what drugs are going on, how much fluids has he had, what were the recent investigations. So this has definitely helped us in better care for the patients, better quality for them. Definitely helps our junior colleagues in making decisions better, and it has made our life much easier. We come into the hospital knowing exactly what has happened overnight. So driving in the car, sitting in the back of the seat, you can just browse through the patient details, and you're spending lesser amount of time looking at the documents and spending more time doing clinical work. So yeah, so this was just an experience which I thought I can share with you guys of how we are utilizing the phone-based application at our workplace. Yeah, thank you.
Thank you, Arjun. It was very good. One doubt I had is in this monitoring chart, I think the nursing workload will come down. The vitals will be monitored, and then they can get the printout of that monitor instead of that, instead of them manually entering the vitals chart.
Yeah. So the main intention here was to get rid of the papers and try to make sure that everything becomes electronic, so that everyone gets used to it, and that until and unless you start working on something, it doesn't get it doesn't get implemented.
Only few things like GCS score or urine output, they have to enter it, I think, in the system.
They will have to, yes, they will have to. Yeah. Again, still we are working on it. It is just a small baby steps. It has just been a couple of years now. It's just been a year and a half now. Everybody is still learning. We've got about 1,400 intensive care staffs, nursing staff. So, and again, there's a lot of attrition going on. So learning is a big problem for us. Teaching the nurses, new nurses coming in, so that attrition is a problem. So that is why it is just taking time for us to come up. So hopefully, in a few years' time, we will work out a plan. But it has definitely helped us intensivists. So we are able to cover the intensive care units 24/7. We run a cardiac intensive care unit and as well. So it becomes easier for us to help with ECMO patients, with IABP patients, with pulmonary artery catheter. Again, all the cardiac output monitors are easily seen by us. So it is definitely helping the people on the phone to give better care.
So Ashish sir, regarding the data privacy, patient data privacy and confidentiality. So whatever the company whatever the company is, hospital is getting attached or something like that, but that data, they can always have an access to that. So how to make sure that data privacy is ensured to the patient's data?
So, I mean, from our perspective, we do continuous monitoring of patients who are in the hospital, and the vital signs are being transmitted internally, staying on our internal server, going to a device cloud server, and then coming to our continuous monitoring stations. That is they we there is no patients don't have access to that data. That data just stays within the hospital firewall, and the only people who have access to it is the providers in the hospital. If I'm, at least with the monitoring inside the hospital. I think the bigger challenge is patients going home, and when the data is on their, private Wi-Fi networks and things like that. That that is a bigger challenge. For now, we are not, the way we have our home monitoring is that we don't, the patients don't have, like, the apps like Arjun showed here. We don't allow patients to see their continuous vital signs on an application. If they're going home, they're wearing a device, the vital signs are being seen back in the hospital, right? The patient cannot open an app and see their own vital signs. They can check obviously, some of these devices, the vital signs are also visible. They can check them. So there is a threat of data privacy there, but we're trying to minimize it that way. Now, I will say that, I'm actually intrigued with what Arjun showed. As I understood it, you are allowing patients to see their own continuous vital signs on
No,
an
no,
app.
Only
no,
for
No,
not at
doctors.
only the physicians.
For
only
the
the, and
physicians.
it is only
Okay,
for the primary doctors.
Mm.
okay,
So for
okay,
the primary, these are the patients who are in the intensive care unit who are
okay,
connected to the monitors.
okay,
While at workplace, we have everything on the computer on the wheels. So there is an Atma application. So we open it on them and we see that. But once we come back home, we try to put rosters for the consultants to cover the unit from 10 to 8 in the morning, 10 p.m. in the
hmm
night, in the morning. And only those people are, and it is through the hospital van, through the hospital Wi-Fi and all of that. And the data is with the hospital servers. Although it's not,
okay,
again, 100% foolproof, but they
uh-huh.
are working on security issues there as well.
So right now patients are not going home
No,
with vital sign monitoring.
no, not at all. This
Okay,
is this is completely
In the ICU.
for patients in the intensive care unit only. Yeah.
okay, okay,
So
makes
there is
sense.
no wearable devices. This is our hospital minder device, a GE device, yeah.
Got
Hmm. Sir, you were telling about like a remote monitoring device at home. What is the criteria? Which patient do we recommend who are getting discharged from the ICU or hospital? What type of patients will recommend a remote monitoring system at home?
Yeah, so that's a good question. I think for us, the first thing we look at is like how motivated the patient is and how digitally connected they are. You know, so even in the US, patients who live close to an urban area are more connected with their digital devices and have continuous access to Wi-Fi. If you go out in the countryside, then there's areas that don't have Wi-Fi. Or, there are patients who cannot afford having digital devices at home. So we obviously cannot include those patients. So first thing is patient motivation, their ability to handle digital devices and tools and have continuous access to at least a Wi-Fi signal. The second thing is, patients who we feel would have chronic illnesses that could be better managed with continuous monitoring, which would include patients who need aggressive monitoring of blood pressure, aggressive monitoring of oxygen saturation. Suppose there's patients with, say, underlying heart failure who you managed for some other problem, but you're worried that if they go home, they're not going to take their diuretics or their antihypertensives, and they're going to go into fluid overload, then you are going to, give them instructions that they have to that then continuous oxygen saturation, heart rate, and blood pressure becomes important for them, right? So we do have some patient selection criteria where we look at patient motivation, um, the ability to handle digital tools, and where we feel that we can send them home early and free up a hospital bed and still have the ability to control uh, some of these basic conditions like blood pressure, heart failure, diabetes, and things of that nature. What we are also doing is that, at least in some institutions, we just don't send patients home on a some sort of digital tool. We also have nursing follow-up, which means our advanced practice providers are then going and checking in on these patients at least once a day to make sure that they are handling these devices properly and that they have no other problems, right? Because one of the problems is that you give patients all these devices and they're not wearing them properly, or then you're getting a lot of artifactual signal, or they are indeed sicker and we're not able to pick that out.
So presently, I think to start with, we are planning for post liver transplantation or post cardiac complicated cardiac surgery patients. Basically, we have few questions there. Are there any
So again,
guidelines?
I didn't,
Yeah.
I didn't add cardiac surgery, and so again, at one of our centers, we've done it with cardiac surgery. So, but we do it slightly differently. We have an application where where a provider does a video call with the patient every single day after they go home after cardiac surgery, and patients take pictures actually of their sternotomy wound and send it back to the providers. Providers do a daily video call with the patient and then daily vital signs with the patients. We've actually shown great benefit with that. And we've been able to decrease hospital readmission rates very significantly with that system. So again, cardiac surgery, again, yeah, I think that's a good one to choose.
Hmm. We have an interesting question from Manu Verma. Is there
Mhm.
any policy, government policy for remote monitoring system in India or elsewhere in the world?
Maybe Arjun can talk about India.
Oh,
Yeah, I am not aware of a policy in by the government for
yeah.
remote
Yeah,
monitoring.
in India, we have a policy for telehealth, but
Yeah,
for remote monitoring system separately, we don't have. But telehealth, there is a policy, sir.
for
Government's
tele
policy is
ICU,
there.
yes.
So in US, do you have a?
Similarly, no real policies around all of this. In fact, to be very honest, we still need to create more awareness around all of this. I don't think there is enough awareness around all of this either.
Yeah. Are there any guidelines, sir, which is recommending these indications or something like that?
Unfortunately not. Again, there is no standardization of how frequently patients should be monitored either within the hospital or outside the hospital. And again, a lot of work needs to be done in this area.
Hmm. So another question is, what is the role of artificial intelligence and machine learning in this pattern of alarms, all those things, sir?
Again, from my perspective, I think there's a huge opportunity. There is some early wins. There is some device companies that are now coming in with third-party software that is layering between the device and a central monitoring platform where they're able to decrease the number of false alarms. So filter the false alarms and only allow the true signals to go through, so nurses don't feel alarm fatigue, right? So there's appropriate response to true signals. That is something that I have seen. Obviously, the real opportunity for AI and machine learning is to use these patterns of vital signs to be able to predict a deteriorating patient ahead of time in a dynamic manner. Okay. So 15 minutes from now, your patient is likely to have a rapid response or to have an acute deterioration. If that can be predicted in a dynamic manner, that would be really helpful. And there's a lot of interest in this area, but nothing that is actually out there right now.
Okay. Yeah, that was a major issue, sir, regarding the false alarms. Many of the patients had a false alarms, and it was very much alarm fatigue was more with the nurses, like who are monitoring that one. It was a real issue
Absolutely.
for us when we start that one.
Yeah, I mean, I'm sure it's the same way in India and the US. Like one nurse on the floor has at least 6 to 8 patients that they're taking care of, right? And they are doing, they are doing medications, they're taking care of the patients. Otherwise, they're rounding with the doctors. They're busy, right? And they have a documentation workload as well. So if you are dealing with even 3 to 4 alarms per patient per hour that are false alarms, then that really just is too much to handle.
So in your slides, one of your slides was showing like rapid response team rate has reduced after starting the remote monitoring system. Actually, it was other way around for us. Actually, after starting the remote monitoring devices and all, the rapid response, we call it as MedCall team. So medical emergency team call. So those calls have increased actually. So any takes on that?
So that's interesting, and I actually always think it's going to be like a biphasic response, right? So initially, when you implement it, you're going to see a lot of these vital signs that you would have never seen otherwise, right? That because you would have checked intermittently, now you're checking continuously. So you're going to see a lot of these vital signs that are going to trigger rapid responses. The Ultimately, if you train your primary providers and you empower them to intervene early, then you should be able to over time see a decrease in rapid response calls because say say your rapid response is being triggered because of hypoxia hopefully is not going to happen all of a sudden. It's going to be a gradual deterioration, or hypoventilation for that matter. Or so hopefully your providers are then going to be able to intervene early to not allow the rapid response stage to be reached, right? Early on, that's not going to be the case. Early on, you're going to see a lot more rapid response calls, but hopefully over time, they're going to decrease.
So nowadays, the many sudden cardiac death in the young patients who are in the gym or exercises and all, what type of device do you recommend for them? Or
Well, I don't know what devices are available in India. It's there's a standard set of devices that have like a smart patch that's going to continuously monitor your heart rate and oxygen saturation at minimum. Continuous blood pressure monitoring is always a big challenge with ambulatory patients, especially with patches and things like that. There is some finger cuff technology that does monitor blood pressure continuously. It there's a lot of artifact to it, especially when you're doing vigorous exercise. So I do recommend one of those heart rate monitors. There's also heart rate monitors with continuous single lead EKG. Do recommend one of those. They Here there's something called a Zoll patch that people at the risk will put on themselves. That continuously monitors heart rate and single lead EKG.
mhm. So another question, I think, any study which shows the role of remote monitoring device in renal replacement therapy patients undergoing intermittent dialysis patients?
Not that I'm aware of, not specifically for that indication. I don't know if Arjun or you are aware of anything like that.
Yeah, there are some artificial intelligence like a prediction models which will predict the uh, intradialytic hypotension with these monitoring devices.
Hmm.
A few devices which will predict that this patient might have hypertension during dialysis, intradialytic hypotension. So apart from that, I don't have any idea about that. Um, so regarding the insurance for this remote monitoring device in the ward, in India it is covered, sir. In US, is it the same? Does
By
insurance
insurance,
cover?
so no, so that's again one of the problems. Right now, hospitals have to invest upfront in these continuous monitoring devices, and there is no coverage by insurance. There is no patients are obviously we don't. So the system works differently. We don't charge our patients for monitoring, right? Um, the hospital will invest in continuous monitoring. And if you come to the hospital, then these devices will be for free for you as a patient. Insurance is not covering them, and the hospitals are also not getting any direct return on investment, because we cannot bill extra, for our time based on continuous monitoring, which is one of the challenges here in the US, and in terms of return on investment.
Are there any potential blind spots while using system like this type of device? Is another question by, I think, Edunath.
I mean, the biggest blind spot in my opinion is trying to separate false alarms from true alarms. I think that's a huge problem. I think the problem of false alarms is very real, and you have to be very, very careful with that. You also have to set your thresholds properly. So, the way we are doing it is that we are able to set specific thresholds, personalized thresholds. If we know that there's a young patient who's had trauma and is going to be in pain and is tachycardic but can tolerate tachycardia, then we'll set a heart rate threshold of 150 on that patient, right? But if we know it's a 80-year-old with coronary artery disease, then we are going to set a lower heart rate threshold, because the risk of myocardial injury is much more in an 80-year-old. So we personalize thresholds. That way we're, at least able to, we're not getting exhausted by alarms. I also showed you, like, our low oxygen saturation threshold is 85%, because we don't want, there's a lot of patients who their oxygen saturation swings between 95 to 90 at baseline. They're older, they have COPD, they wear oxygen at home. So there's no point setting an O2 sat alarm at like 92, 93. They're going to continuously alarm. You can't fix it. So we personalize that. The other thing we do is that our devices also allow a delay at the level of the device, which means that you have to be above a threshold for a continuous 3 minutes for the device to send a signal to the central monitoring station, which is helpful, because then all of those things that your patient is eating in bed or rolling over in bed or the device is getting at least all of those alarms are not coming through, right? So those are some things we are doing. But again, the biggest blind spot, in my opinion, is dealing with alarms and making sort of more personalized precision alarms here.
So what is the pathway user in the central monitoring station? The nurses will be monitoring, and then it will be escalated according to the criteria to the physician. Is it?
So for our hospital on the floor, our nurses carry these phones, or like little paging phones, right? So if I'm a nurse and I have 8 patients who have continuous monitoring, then if any patient reaches their threshold, then my phone will ring, right? I can either choose to accept the alarm, go check the patient, or I can just, the phone keeps on ringing and I don't answer it. Then all of the other nurses on the ward, their phone will also ring. Okay. If none of the nurses on the ward respond, then the unit manager's phone goes off. So it's an escalating internal system of alarms. There's also a central monitoring station where everyone can see it, but everyone carries the phone as well.
I think we covered most of the questions, sir. And few words on hospital at home, sir. With this, I think we should.
I mean, hospital at home, I think it's a huge opportunity. We already talked about it. We have some success with cardiac surgery. We have some success with our chronic medical patients. I think the biggest issue there also will be, are you choosing the right patients who can handle the devices? And then for us, the hospital at home also means there will be a provider who will go check in on these patients at least once a day for the first few days. I think there's a huge opportunity. And the opportunity there is decreasing readmission rates and then allowing patients to discharge early from hospitals. So I think I think the future is pretty bright when it comes to hospital at home.
Yeah. I think with this we came to the end of this webinar, sir. Thank you for accepting, and it was an excellent discussion went on remote monitoring device. Thank you, sir.
Thank you
Thank
so
you,
much,
Arjun.
and liked talking to you guys, and very impressed with what you all are doing, Arjun, and would love to stay connected.
Yeah. Thanks, sir.
Okay.
Thank you, sir. Thank you.
All right. Take care. All right. Bye-bye.